Okay, so I'm going to talk about predicting outcomes in vascular surgery and hopefully shed some light on when not to operate. But I think one of the things that we're all facing as surgeons, not just vascular surgeons, is there's rapid changes in interventional options that we all have in managing our patients, and obviously changes in the patient profile. So we're seeing a lot of older patients with a lot of comorbidities, and in fact in vascular we're seeing a lot of young patients with a lot of the comorbidities that we didn't used to see at relatively young ages. And I think it would be fair to say our patients and their families have different expectations than they did a number of years ago. So I think all this makes all of our jobs quite a lot more difficult. And perhaps from our first talk, sometimes we just it's easier just to say, well, let's go and do something, because kind of everyone's expecting it quite often, and it doesn't always necessarily mean it's the right answer. You sure that? I was hitting that button you told me, but
page down works.
Yeah, no, that's one. Okay, yep. Okay, so I thought I'd talk about two groups. Basically, in our elderly group of patients, aortic interventions and all vascular admissions. We've got pretty good data on both of these. So, in terms of aortic interventions, I thought we'd talk about aortic aneurysm repair, both open and endoluminal repair, and also occlusive disease. So we can perform angioplastic stenting or hybrid procedures where we do an open and endovascular technique, and bypass surgery, obviously, and also talk about patients that are just coming in under vascular units. So we've got two actually quite contemporary and good sources of data. Firstly, ASINIP, which is obviously run by the college, undertook an audit of endovascular aneurysm repair and looked at about 1,000 cases from 1999 to 2001, and we've actually followed those patients for 8 years and developed a predictive model. And we're actually revalidating that model and modifying the model as at the moment with NH&MRC funding. And also, many surgeons certainly will be aware that the ANZ Society for Vascular Surgery has a national or Australasian audit and has looked at now collected data on nearly 14,000 patients who've had aortic procedures in the last 5 years in Australia and New Zealand. So we'll look at that data as well. So looking at aortic mortality in Australia and New Zealand, overall open elective mortality is about 3.5%, open ruptured 34%, endoluminal aneurysm repair in the elective setting less than 1% mortality, and in the ruptured setting about 18% mortality. So basically, the factors that were found in the AVA, or our binational audit, that affected perioperative mortality were the presence of ischemic heart disease, age greater than 80 years, female gender, and obviously rupture. There are a few other sort of more subtle influences, but they're the main ones. And the perioperative factors were greater than 4 litre blood loss, suprarenal clamp, and presence of a suprarenal aneurysm. And all those things, as Greg said, were quite self-explanatory, I guess. So with endovascular repair, we know that that requires anatomical suitability, and procedural mortality does vary. It can be less than 1%, which is obviously in a national database what we're getting at the moment, but in individual cases can be 10% or more in some elective settings. So this is, for those of you that don't sort of see much vascular surgery, this is an aneurysm obviously in a stent graft with suprarenal fixation, bare metal stent, and the graft going into the iliac arteries. And this is a spiral CT scan post-operatively of the graft in situ. And basically when we actually work these patients up, we're looking at the sort of features of the infrarenal neck, how long it is, how wide it is, and the angulation and diameter. The aneurysm size, obviously, and the features of iliac arteries. And one of the reasons quite often in women we can't do the graft is because the iliac arteries are too small to deliver the device into the aorta. These are quite nice to show the patients because it's they actually get a pretty good feel for what's going on, but it's actually not that useful as such. So in terms of, we actually recently just published looking at 1 year survival. So one of the things that you see, I think, and actually it was mentioned in the first talk, is we actually are very good at getting the patients through a procedure and getting out of hospital. So if you look at that national data, there was a less than 1% mortality, and the patients get out of hospital usually in 2 or 3 days. But what we do know is that actually about 7 to 12% of our patients actually die within 12 months of aneurysm surgery. And that's not the ones that we've said aren't fit for an operation. These are the ones that actually underwent the procedure. And so what we found actually when we did multivariate analysis was ASA was highly correlated with 1-year mortality. And so if you went from an ASA2 to ASA4, there was a 3 times increase in your perioperative mortality, and I'll show you some life table analysis in a minute. Interestingly, aneurysm diameter has been shown by us and other groups that even though once you fix the aneurysm, you think, well, that's done and dusted, the actual aneurysm size preoperatively does significantly affect long-term survival, and no one really knows why, and it may be related to biomarkers involved in aneurysm formation that also are associated with plaque stability and atherosclerosis or something like that, but no one's really sure. Renal function is incredibly important in short and long-term survival. So our 3 and 5 year mortality is also highly correlated with renal function. Respiratory function and iliac artery calcification also seem to be quite significant influences on outcome. So when we looked at 3 and 5 year survival, we also found that age, aneurysm diameter and ASA were important, and at 5 year survival, creatinine was really important as well. So one of the problems that we have as vascular surgeons, I think, is that actually if you look at all our aneurysms, over 60%, and in the recent data it was about 70% of our patients are ASA3, so they have severe systemic disease. So that's actually covers kind of a multitude of sins, if you like. So some ASA3 patients, you know, are actually playing bowls every day or playing golf and really quite active, and other ASA3 patients potter around the house and really that's the end of it. And so it really is quite hard to tease out what ASA means in an individual patient. So when we actually collected the data for our current study, we asked the following questions, and this is self-reported, so it's not, you know, we don't put the patients on treadmills and all that sort of stuff, but just can you walk up 2 flights of stairs, so it's about 40 steps, and can you walk 1 kilometre briskly, which is about 5 kilometres an hour? And I suspect that's a bit of an overcall because 5 k's an hour is actually a reasonable pace. But anyway, and then with these patients that because it was a multi-centre study, we collected data from the National Death Index. So each state sends the deaths in that state to the Commonwealth Government. And so we're able to access that data so that if you have an operation in Melbourne and die in Queensland, as a lot of our patients sort of tend to migrate north, and it's not a bad idea at the moment, I guess, in Adelaide. But anyway, then at least we find out that they're not lost to follow-up, they've actually died. And so we're actually able to look at this as an independent variable. And as I mentioned before, we found quite a wide separation of mortality between ASA3A, the fit patients, and the unfit patients. That was highly significant, and it really started quite early after the procedure. So as an unadjusted analysis, the fit group were, the unfit group were 3.5 times more likely to die during follow-up, and after adjusting for comorbidities, it was still a very high correlation so 3 times more likely to die in the perioperative period, not just at 12 months, but during follow-up. So really, the fitness of the patient is incredibly important, but it's actually really hard to tease out if you just look at the numbers. So I guess that's something that, as clinicians, we sort of look at the patient and talk to them, see how they get out of the chair onto the bed and walk around, and we actually use that, I think, in sort of working out whether we should be operating on the patient. But actually, if you look at it on paper, we look at age, ASA, renal function, have they had a heart attack, that sort of thing. And that frailty doesn't really come into the calculation on the papers that we see. So the other thing we did was we've actually developed a sort of risk model for endovascular aneurysm outcomes, and a lot of the stuff here is actually kind of very specialised. But we looked at both perioperative mortality and 3 and 5 year survival, but we also looked at technical success of the graft. But if you actually look at this is the average patient in the ASINIT data set. So a 6 centimetre aneurysm, 75-year-old patient, ASA3, normal renal function, and sort of fairly normal aneurysm anatomy. And the prediction was early death, so at the time of hospitalisation of 1%, and your 95% confidence intervals of between 1 and 3%. But we can actually calculate 3 and 5 year survival. So 3-year survival on average is 80%, 5-year survival 67%. Was that someone's glass or was that your?
It wasn't.
Okay. Okay. So this is the average patient in Australia. Now this is the Queen Liz patient. Okay. So which doesn't actually stop doing vascular surgery last week, I might add. But if you've got an 84-year-old patient with an 8 centimetre aneurysm, ASA4, moderate renal impairment, and sort of reasonably standard aortic anatomy, their early death rate is 7%, and you can see 95% confidence intervals 3 to 14%. But their 3-year survival is 38% and 5-year survival 23%. So when you sit down and have a discussion with the patient about whether we should be fixing their aneurysm, if you just have a sort of glib answer, the average mortality is 1% and you're likely to survive 3 and 5 years is 80% or 70%, that's actually not that accurate in individual cases. So you really want sort of, if you like, personalised prediction of outcomes. And we actually have that as an iPad, as David said, if you actually go to a vascular meeting, everyone's got their iPad or their iPhone out. So if you actually want them to use anything, it has to be usable on an iPad or an iPhone. So that's just what we were looking at on an iPad or iPhone app. So I think you could safely say that those patients with high perioperative mortalities are also much less likely to get home and not have to go to a care facility. And one of the things that we've been bad at, I think, is concentrate as surgeons, particularly vascular, but it might be all surgeons, I guess. We concentrate on perioperative mortality and, say, stroke after carotids and stuff, but not actually how the patients do and whether they get home and go to a care facility. So what happened recently is Addenbrooke's Hospital, which is one of the biggest units in the UK, looked at all the patients admitted to the vascular unit over 65 years of age and who stayed for more than 2 days. So they took out all the patients that were relatively young and had day procedures or one-night stays. This was in a 12-month period. So basically what they wanted to do was look at factors that were associated with increased mortality and also likelihood of going to a care facility, so in other words not getting home. So the factors that they actually had quite a high 12-month mortality. So this is just all patients coming in, not just aneurysms or anything else. And anemia on admission, not independently mobile, on at least 8 meds or with high comorbidity index, signs of malnutrition, history of falls, depression, and emergency admission, all highly correlated with 12-month mortality. And predictors of discharge to a care facility were, once again, age, emergency admission, high comorbidities, polypharmacy, poor mobility, malnutrition, poor memory problems, and history of falls. None of this is rocket science, but it's not something we necessarily think about every day when we have someone come in under us with a problem and we're not sure how aggressive we should be in managing them. So they looked at frailty characteristics and developed a frailty score, which is based on those factors. So they had comorbidities, and they used polypharmacy as well as a number of medical comorbidities, anemia and mobility in terms of physical function, nutrition, cognition, geriatric syndrome, so history of falls and visual impairment, and living alone as social vulnerability. And they were all strong predictors of 12-month mortality, discharge to a care institution, prolonged length of stay and likelihood of readmission. I guess the question that they raised, and I don't know the answer to it, and maybe Katie Gibbon will answer it for us, is will modification of these features actually help improve outcomes? Because I guess it's kind of nice to know that these are important factors in terms of these adverse outcomes, but what can we do to improve the situation? And I don't know the answer to that, but I'll ask Katie, I always do, and she always tells me. Okay, so basically they developed a 6-factor score, and Waterloo scores a nursing sort of score in terms of likelihood of developing ulcers and its nutrition, likelihood of developing pressure areas, that sort of thing. And then basically, depending on the number of those factors you get, they looked at 12-month mortality, and you can see that goes up quite dramatically with the number of frailty factors that you're positive on, and readmission rate basically goes up. Readmission-free survival drops down quite dramatically as you acquire more frailty points, if you like. So one quick 1 minute or 30-second talk. There's a study in France where they looked at factors associated with 12-month mortality or non-fatal stroke or non-fatal myocardial infarct. And once again, they scored the patients on the basis of age, previous MI, poor renal function, low or low ankle brachial index, high inflammatory markers, and the absence. So you get a negative score if you're on a statin, on appropriate medical therapy. And the more points you got, the risk of mortality went up, and they externally validated in a separate, different unit. So you can see that this is a fairly consistent theme across certainly vascular surgery. So why do we use decision support tools? Well, I think they help the surgeon achieve better outcomes by providing more personally relevant information to patients. Most surgeons would like, at least they say they do anyway, would like tools to support information exchange between themselves and their patients. I think it's good to identify high-risk patients and patients who are likely to have poor outcomes. They're certainly important in the auditing process because you have to be able to compare apples and apples, if you like. It's important in policy making and research, and if patients understand how the decision, what's influencing decision making, I think that's really a pretty important process, and we've sort of had some discussion about that earlier. So I'll stop there, probably a bit over time. But, okay.